A number of you know about atraumatic restorative technique, and it is the one thing that we can talk about that truly has international applications. Certainly those of you from overseas, outside of the UK, may know about ART, but it's not had very much use in Europe, for instance. So I'd like to introduce the atraumatic restorative technique, and by the time we're finished you should be able to define it, describe the procedure, which is a very clinical thing and something we need to know about, but from our perspective not overly interesting, but then think about the quality of ART as a public health approach. So if we move on to the first of those objectives to define it, and this isn't going to take long, ART is a restorative procedure in which caries is excavated using hand instruments, and then the tooth is restored only with a glass ionomer cement. So hand removal of caries and sticking glass ionomer in. And it was developed in Tanzania in the 1980s by Joe Frenken, and then subsequently endorsed by the World Health Organization. And quite a lot of the data that I'm going to cite come from people who've worked with Joe Frenken on this. So, if I may say so, slightly boring, very clinical bit about what we do with ART. First of all, the cavities must involve dentine. There isn't really any point doing a filling unless the cavity involves dentine, is there? And by the very nature of the technique, then the cavities have to be accessible to hand instruments, and ART works better for single surface cavities than multiple surface cavities. And you could imagine that if you're trying to splodge in some glass ionomer cement, it's easier to do that if the cavity is entirely contained, as it would be if it was an occlusal or a buccal cavity. Whereas if you've got a mesial or a distal box on a molar, then there's more surface area in which the glass ionomer can be dissolved if it's soluble, but also more opportunities for it to leak, and even more opportunities for the glass ionomer to get out as you put it in. So single surface cavities are the most appropriate. Because it's regarded as a fairly minimal intervention technique, it's obviously not suitable when the caries is very deep, and particularly it's not suitable if there's inflammation of the pulp, if the pulp is exposed, or if there's even more severe infection such as a dental abscess, and so on and so forth. So really think of this in the old style as being analogous to class 1, class 2, and perhaps occasionally class 3 cavities, really. And the indications and so on are the same. Again, hand instrumentation is the thing. So if you can't get a hand instrument in there, then it won't work. It's not a high technology solution, so it doesn't need dental chairs, and that's its beauty. We don't need fantastic working environment, but nonetheless, like anything else in life, you're going to be better at it if you can work comfortably and see, and so on and so forth. So you need a good working environment in and outside of the mouth. Now that might mean working on a table with the dentist sat on an office chair and a child lying on a table, or a child lying on a bench. It might mean working outside underneath a tree, or it might mean working outside of a school classroom. In a school classroom. So that, again, just somewhere where you can be comfortable, where you won't be too disturbed, where there's good light, and it's relatively clean and dry. Generally best with the patient lying horizontally in front of the operator, and you've all had teaching on good posture at dental school, and that's even more important with ART, because operator tiredness is a big problem with ART. So the best operating position that you can find. It needs a small range of hand instruments, which you can't work without. You nonetheless need good infection control, so that's the creation of a small area which is clean for operating, and the opportunity to sterilize the instruments. But that doesn't necessarily need to mean an autoclave, but could be done in a pressure cooker or something like that. So all you need is relatively clean water, a pressure cooker, and a heat source. So it's not like a European or an American system where you need mains electricity. And then glass ionomer cement, which I can understand would be a significant cost, but actually not a very large cost on a cavity by cavity basis. Let's crack through this procedure very quickly. There's no need to go through this too much. We'll make sure that you have access to the slides, and you will need to know this, but not in phenomenal detail. All dental procedures need the tooth to be isolated so that it doesn't get dirty and wet with saliva. The tooth needs to be cleaned, and then using a small excavator. Would you be familiar with an excavator? Yep. So a small excavator to break away the enamel over the cavity. And it has to be small because at this stage you may just be working on enamel, which is very hard, very strong, although it's unsupported. But with a small instrument you can apply more force to a smaller area and break away the unsupported enamel. And then the carious dentine is removed with excavators of the right shape to get into the relevant part of the cavity. And then the cavity is cleaned with cotton wool and water. If necessary, if the cavity is deep and approaching the pulp, you can line the cavity with calcium hydroxide paste, Dical, or whatever it is that you use. And it's necessary to condition the cavity wall's occlusal surface with it's citric acid, isn't it, that's used? Citric acid to clean the dentine and the remaining enamel to ensure that you get good adhesion. We'll talk about this later on, but one of the great beauties of this technique is the glass ionomer cement is adhesive, so that you don't, if you can have good adhesion, you don't need to make the cavity particularly retentive. The adhesive properties of the cement hold the filling in place. And then overfill the cavity, and literally with a gloved finger condense, in common parlance I want to call that splodge, the glass ionomer cement right into the cavity and press it down with a finger pressure technique, and then tidy up the occlusion with excavators or carving instruments. Okay, so actually very straightforward technique, and if you've done amalgam cavities you'll see that that is much more straightforward. As I say, the excess material is removed with a carver. Again, adjust the occlusion, and then finally smear some petroleum jelly, Vaseline, or whatever it is over the glass ionomer cement so that it can set without dissolving in the saliva. It's slightly more soluble before it sets completely, and ask the patient not to eat for about an hour. If there are proximal cavities on the mesial and the distal, then various strips and wedges, mylar strips, and so on and so forth, to create the best proximal contour that you can. Okay? It's wrong to think that splodging in glass ionomer cement is the whole deal, and that this should be seen as part of a total package of care. So that, as in any other form of dentistry, we'd want there to be preventive advice, advising people about diet, plaque removal, if these are children who are getting caries, then they're going to benefit from the application of topical fluoride, either in toothpaste and or professionally applied gels and varnishes, and any other things that are needed. In addition, the glass ionomer cement can be used as a fissure sealant. And again, if we've done a filling in a child, we know that child is high risk for caries, and so that there might be a case for applying fissure sealants to the remaining, particularly first molars. And it will be mostly first molars, and I'll tell you why that is the case in a moment. So don't just see the filling as the whole deal. It's part of a package of care, as it would be for any other patient and any other form of restorative technique. A list of the instruments, so a mirror, tweezers, probe, an access cutter, hatchets, a range of excavators, a mixing pad and a spatula, and this device they call the applier carver that you can put the material in with. So that you can see that this is quite an appealing technique, very narrow range of instruments, not requiring the huge range of expertise of a dentist to do this. Because it's fairly low tech, then it can be done in lots and lots of different settings. So it's beginning to look like a potentially attractive technique. The hand instruments are particularly useful. They allow us to get access, but by their very nature they're conservative. So it's very difficult to remove sound enamel, or practically impossible to remove sound enamel, and very difficult to remove sound dentine with an excavator. As soon as the dentine is sound, the excavator won't cut into it. So it's a very conservative technique, and I've mentioned that it requires very little economy, very little physical infrastructure in terms of light and power. I'm going to talk about how children tend to find it more comfortable, and again the very narrow range of instruments and the simplicity of the technique. Simplicity is perhaps a dangerous word to use because it's not easy to do ART, but the narrow range of instruments and so on and so forth mean that infection control is also very straightforward. I've mentioned using glass ionomer. We'll talk about this a little bit more, but to ease you into all of this, first of all, it's adhesive, and then secondly, it contains and therefore releases fluoride over a period of, well, some time, depending on who you listen to, after it's been placed. And it's very easy to use. It's quite easy to use in the mouth, but it's also very easy to mix because you simply mix powder and water, and it doesn't require amalgamators, doesn't require special carving or condensing instruments, and it can be mixed on a bit of paper.